Thank you very much, and thank you for organizing this great workshop. So, so the Sabin Vaccine Institute is a 25-year-old organization based in Washington, D.C., named after Albert Sabin, who was one of the developers of a polio vaccine. And I think importantly, not only was he a developer of a vaccine, but he was a proponent for its use. And you can see now how far that has gone. And the Institute was really created with that vision, to ensure that that vaccines were available to populations who could need them, that there was adequate access, and that knowledge and innovation were a piece of it as well. So that really is the theme of what Sabin is doing now. I think that the idea, what intrigued me when we heard from the World Federation about this, was about capacity building, and with a focus on the healthcare worker, because we believe that's really a fundamental part of the system, particularly for immunizations, and not only just the healthcare workers, but immunization programs overall. So I think that the emphasis on capacity and capabilities and competency are really the important pieces of this to make sure that the vaccines that are available are actually delivered. I just want to highlight a few of the programs we have at Sabin that integrate with this. One of them is what we call the International Association of Immunization Managers. It's a program that's been supported by the Gates Foundation for several years, and it has a renewed focus on leadership and management. The theory of change is that unless programs are well managed, they won't function well. And often managers get into these positions because of their expertise in some other public health area, but not management per se. So this is a program of trying to help the immunization managers, both at the national level and the subnational level, better manage their programs and with the leadership skills that are needed. We've also, in the context of the concerns about vaccine acceptance and vaccine hesitancy, we've just launched a new program called the Vaccine Acceptance Research Network. And this has really come about with the revelations we heard earlier about the SAGE report on vaccine hesitancy, and the understanding that this is largely about the decision making and how people process information and make decisions. And with that, this research network is really designed to help the people on the front lines address these problems and trying to integrate a multidisciplinary problem-solving approach with an emphasis on social behavioral sciences. And then finally, I think also in service of this, and we've heard some other discussions about this, and it really fits in with the charter, is trying to help the discussions about immunizations wherever they may be. Ciro de Quadros, who came to the Sabin Vaccine Institute from PAHO several years ago, started a program on journalism training in Latin America, and we're now expanding that. And the idea is that this is a complicated business. The science of vaccines is complicated, immunization programs are complicated, there now is politics on top of it, and unless journalists have good sources of information, then they may not cover the topics well. So part of what we're beginning now is to expand that program the way we began in Latin America and in introducing this in other countries. And we have a partnership now with the Thomson Reuters Foundation to try to better help align the journalists and the vaccine professionals to get them together and to also be able to develop sources for these journalists. So with that, one last piece is about advocacy, which is obviously an important theme of the charter, is the importance of the healthcare workers as advocates. There's many people that need to advocate, but the way I think about this, if healthcare workers aren't part of the solution, they'll be part of the problem. So we have to make sure that we can help them be better advocates, advocates to their patients, advocates to their communities, advocates to journalism, and advocates to their leaders.
Great. Thank you so much, Bruce. Viviana?
Good morning. Can you hear me well?
Yeah.
I represent WONCA, the World Organization of Family Doctors. WONCA represents 500,000 family doctors, general practitioners in about 150 countries working at the front line of primary health care. Primary health care provides the basis of a strong health system essential to achieve universal health coverage. What is it? What is our role? What do we do in primary health care as family physicians? We do prevention, we do reproductive, prenatal care, maternal, adult, and child health, health emergency responsiveness and follow-up of those affected by those emergencies, diagnosis and treatment of communicable and non-communicable diseases, diagnosis and management of chronic conditions, including multimorbidities, treatment of addiction and other mental health problems, and palliative care. Universal health coverage cannot be achieved without comprehensive, integrated, person-centered primary care services. And comprehensive primary care team, or primary care cannot be achieved without qualified primary care teams. Vaccines and medicines need a functioning primary health care system for their delivery. Primary health care is essential for the achievement of equitable and cost-effective universal health care. When I was invited to speak about the role of family doctors in vaccinations, I knew of my own experience working in a developed country, working in the United States for the last 30 years. But I set about to learn about what our organizations, the different organizations of family medicine, were doing around the world, and what individual family doctors were doing in their own practices and health centers in regards to immunizations. How do people get vaccinated? When a child comes into the office for their preventive visit, the doctors assess development, nutritional status, and immunization status. When adults come to the office for the treatment of their chronic diseases, doctors assess their immunization status. When a pregnant woman comes to the office, we aim to protect the mother and the baby in the womb. Family doctors work with their nurses to make sure the patient's schedule of vaccine has been followed. They update when necessary. Many family doctors around the world do work in private practices, but many work in health departments. So they either do the vaccination in their own clinics, in cases where the public health is integrated into the practice, or refer them to the health departments. Some sites have a separate floor or office area dedicated just to immunizations only, to avoid mixing people who may be ill at the same time as they're coming into their preventive service visits. In some countries, vaccination campaigns are done in the schools, and doctors are not providing the immunizations in their clinics. Doctors welcome that schools pay attention to whether kids and adolescents are vaccinated and have them updated. It is always a welcome visit to my office when I see that a college or a school send a child to my office to be vaccinated because they noticed that they were not up to date. Hospitals also pay attention to the vaccines as well, often making sure that adults are vaccinated against pneumococcus or flu before discharge back to their home or their community. Medical school and postgraduate training in epidemiology, vaccine science, participation in vaccine campaigns, work with their health department, understanding the importance of both children and adult vaccinations. And preventive health is a major part of the training of family doctors. At the organizational level, are running to many websites. It was fascinating for me to see that every region of the world, and WFPHA represents all regions of the world, had really interesting and very advanced websites updated by our member organizations, talking about vaccine schedules and calendars, information for patients and members of the healthcare teams regarding what to expect, the benefits, the concerns, the side effects, and the indications for vaccines. Many family doctors are going to the media, presenting in TV programs, in newspapers, and in websites of all sorts. This was true all across the board and in each region of the world. The American Academy of Family Physicians, in particular, our largest member organization, having 60,000 family doctors working actively right now, more than 100,000 members, covered this under its priority and initiatives. It's one of their priorities and initiatives to accelerate the generation of new knowledge and research to improve population and community health. And they created increasing immunization rates, one of their top priorities. And that was surrounded by a program of policy and advocacy, partnership, training and education, patient education, practice-based research, and resources and tools. Another issue is the American Academy of Family Physicians is celebrating the 10th anniversary of their Vaccine Science Fellowship Program. The overall intent of this program is to develop a cadre of family doctors interested in and knowledgeable about vaccine issues and help address the interface between public health and the family medicine community. Policy and advocacy includes anything from working locally to working federally with the federal government, in particular, recently signing a joint letter to President Trump surrounding the issue of vaccines. We do know that policy in the US affects the rest of the world, and we're very, very concerned as family doctors in the US on what's happening in regards to policies worldwide. We have worked with plenary sessions, working with Secretary of Human Services, Centers for State Policies, and coalitions. We do know that to reach the highest rate of immunizations, we need multi-sector partnerships and partner with all the different organizations, in particular other society and organizations, Center for Disease Controls and Prevention, etc. We cannot do this alone, not family doctors alone, not one organization alone. It takes a multi-state partnership. Training and education is important and happens through national live courses all around the world. Every time there is a meeting of family doctors, there are courses in regards to vaccinations. There are journal contents, sessions at different meetings, and then also, most recently, adding PrEP or PrEP, HIV prophylaxis as part of the training of the family doctor. Resources, just a moment. Resources as tools include even apps and ways that people carry in their pockets to be able to make sure that we all are knowledgeable of those vaccines. We want to take a leadership role in addressing diversity and social determinants of health involved with vaccinations to impact individuals and families, and look at in every country what are the differences and the inequities in regards to vaccination. Rural health is an issue we have identified. Disparities continue to increase in the healthcare and outcomes of rural residents, and making sure that these campaigns get to the most remote rural places as well as urban centers is very important. Some of you talked earlier about this, and I think it's very important. How to address vaccine confidence and patient hesitancy. Family physicians reported that in their offices are following certain barriers to immunizing patients, safety concerns, cost, the chain of having cold vaccines, patient acceptance, supply, leftover vaccines, complexity of the immunization schedule, lack of knowledge by the practice team, and the staff buy-in. Some of the solutions: implementation of evidence-based interventions and quality improvement, motivational interviewing and listening skills. Somebody was talking about that. How do we motivate, especially with the global concern of anti-vaxxers? I want to also highlight some countries reporting no electricity to keep vaccines refrigerated. This has happened recently, particularly in Venezuela. The anti-vaxxer movement has taken all of us by surprise. I'm particularly concerned that in the developed world, many have never lived or seen the devastation of communicable diseases, and therefore do not understand the importance to continue to vaccinate and promote a world free of these elements.
Thank you.
My name is Jon Wardle. I'm from the Australian Research Centre in Complementary and Integrative Medicine in Sydney at the University of Technology, Sydney. We have a broad program of work that explores the interface between TCIM, traditional complementary and integrative medicine, and public health. So one of the areas that we've been funded by the National Health and Medical Research Council to do is to examine the interface between TCIM use and vaccination, childhood vaccination in particular. And I think one of the things we're talking about capacity in this area. TCIM in most countries is up to half the healthcare system. The informal sector is very, very large. And we published a systematic review of TCIM attitudes towards vaccination in 2016 of vaccine. And it may surprise many people in the audience, there are significant elements of vaccine hesitancy or anti-vaccination attitude amongst TCIM practitioners, but the support actually outweighs the opposition. And what our work is showing is simple communication techniques. So because TCIM practitioners aren't included in healthcare systems, they do not get infectious disease notifications or outbreaks. They don't understand, they don't see the measles outbreaks that occur. They don't understand the seriousness. We also, I think, sometimes focus so much on TCIM practitioners, but the reason patients see TCIM practitioners is because of distrust, a desire for more empathic, emotionally engaged communication with their healthcare provider. And this is why people turn to TCIM, traditional and complementary medicine practitioners in place of conventional medical practitioners in many cases. And It is also a very, very key reason why people turn away from vaccines. Public health has an incredible message to sell on vaccines. We just don't do it very well. And we see this again and again. People go to their GP, they say, I've got a few concerns about vaccination. Their parents, they have concerns about everything. I think that's a pretty natural reaction. But often the reaction from the conventional medical provider or the nurse or the midwife is usually one of equal distrust. Oh no, here's another anti-vaccination, vaccine-hesitant parent, I'm frustrated, frustration occurs. So patients turn to the internet, and the first thing they hear is, we understand. And I think that's the thing that we really need to understand with patients. They're not naturally vaccine hesitant. People who use other healthcare systems aren't naturally vaccine hesitant. They just want answers, and they want an emotionally engaged, and they want the respect of being able to discuss these things. And we found people who just believe that natural health can't align with vaccination, but it's low dose, is preventive, it triggers the body's own innate healing responses. It is a natural health intervention almost by definition. And when you explain that to parents, they actually, they understand that they can have a natural health approach to parenting and include that with vaccination. But these tailored information sources which we're developing aren't standard in a lot of communication, and we're finding this is a big gap in towards getting the message out. Sometimes people just distrust the medical system. It doesn't matter what you tell the GP to say, what you tell the nurse to say. Patients just won't believe them. So, we have some innovative strategies where we're using naturopaths in vaccine-hesitant areas to deliver supportive vaccination messages, because people just won't listen to those messages from their conventional medical provider, but they trust their natural medicine provider. So, when we think about capacity and advocacy, obviously we need to be very careful in this space. It is a very contentious space, but we do need to think of these people as a potential resource and opportunity as well as a challenge.
Hello everybody, my name's Adrian. I come from New Zealand. As many of you would know, it's a very small country, almost the antipodes of this very spot. If you drilled through the earth, you would come out somewhere near New Zealand, almost close to Australia, part of it, or you could catch a fly here in 30 hours, or 26 if you come through the Gulf States. So it was a long walk. Look, I'm going to just really start by addressing you in my native tongue first. So, nō reira, tuakau ki te mihi atu kia koutou e hui mai nei I tēnei ai nō reira tēnā no tatu katoa ukurana tērā o ngā hawe whā. I'm speaking my native tongue because it's a vaccination from the chronic disease of colonisation. And so when you meet our people, whether we're speaking amongst ourselves or whether we are fortunate enough to be in fora like this, then we make it our business to use one of the greatest pieces of health that we can offer each other. And that is the retention of our language, which is the glue to most cultures anyway. So we bring it simply to offer that as a welcome. So I welcome your mountains and your rivers and your oceans and those of your people who have died before you that bring you to this place. So we all cast a long shadow. So I'm saying this because I'm kind of offering an Indigenous lens, not the Indigenous lens, but with 370 million, which we suspect is probably more like 400 million people identified by the United Nations as being Indigenous across the planet, and also the unusual tapestry of what that represents. And I want to acknowledge Brazil with over 350 different cultures and nations within nations. So, I come from a privileged place. And so I'm not here out of right. I'm here because it's my duty as someone who's a fourth worlder, an Indigenous person from a first world country that has the currency, the opportunity to be multilingual, but using another of our languages. If you use biblical terms, learn the language of your oppressor and learn it really well. So I'm kind of here to just stand and acknowledge that all the science required with regards to vaccination and immunisation we already have and we know. I've left my laptop over there because I was so moved by the first two speakers, and particularly who actually started to put it right where it belongs. So with regards to NCDs and or communicable diseases, behind, if you want to know the sickest people in your communities, if you have Indigenous folk, they will be behind the 71% of people who will perish as a result of NCDs alone. So there's a place of mistrust. You know, there's a whole veil of people, whether they come from first world countries like my own, or from other countries that were founded on slavery, or those that have those situations within their own nations. A whole nation within a nation with a kind of a cognitive dissonance that doesn't even get them to the door. And so vaccination and immunisation has to join the queue of a significant number of illnesses and ailments that can be arrested and prevented, that people of indigeneity are particularly suffering from. Now, I'm not suggesting they're suffering more than anybody else, but I'm saying they tend to be, in all of our nations, within nations, the ones that are not necessarily meeting the schedules of vaccination and immunisation. So, you know, I offer a lens into that in that sense. I also want to acknowledge that, so this is a really important issue, but it has to stack up alongside other inactivity that's happened within the last period of time. Now, the last thing I want to say is to present an anomaly. Now, I love New Zealand. It's where I come from. My people have been living there for not long, but just about 1,000 years, and seriously considering staying. The thing about it is, the median age for all New Zealanders is 38. The median age for my people is 22. If all of our people, which is only 600,000, emigrated to Australia or somewhere else, and the 300,000 of my other Pacific cousins, because we're the home of most Pacific Islanders, emigrated to Australia, it's easy to say, the median age for New Zealand would move to 46. That would be near Japan. So that says, as we all understand, there's a disproportionate amount of unwellness and burden of unwellness carried by a small sector of the population. Now, I'll just simply say, this is not a white issue trying to get rid of us. I'm just saying. So when starting with vaccinations and immunisation are a really good way to start this. We're not far behind, but we're still behind. And before I hand the mic over, I want to acknowledge Australia and the successful vaccination and immunisation rates of Indigenous Australia. You know, if only they did that in other issues of their society with Indigenous people, it would be a great place to visit. So once again, it's great to be here. I enjoy the opportunity for all sorts of questions and contributions. Kia ora, everybody.
Thank you very much. All our speakers have given us the opportunity to engage with the audience. So I'm going to, we have 4 minutes left from the kind of introductory remarks, so I'm going to add that to the questions. And many of all our 4 panelists, I want to thank you, have already addressed many of the questions that I had, in case you didn't say those things. So thank you so much for those. So I'm going to open the floor and ask for speakers, and I'm going to give first priority to those individuals that haven't spoken. And like the previous time, just ask that you introduce yourself so that you know, we know who you are and which country you're from. So,
I'm Dr. Naveen Thakkar, Executive Director of International Pediatric Association. It is very nice to be here and very good presentation and very good point that we are working on this project, vaccine hesitancy. And it's a very good point that if you really want to, the key point is the building the trust in the community. And you very correctly said that we have to involve others and also family physicians. So we have a program where we train pediatricians on interpersonal communication, social media, media interaction. So I can see many other stakeholders here. So my question is how we can work with, or all of us can work together. Well, it's a very big task. And everybody, we work with Dr. Gellin very closely, but how all of us can come under one umbrella and work together on immunization.
So this is from International Pharmaceutical Students Federation, and I'm from South Korea, working as a chairperson of ASEAN region office. I'm really interested to hear all the speakers per panel, and my question goes to Dr. Gellin. So I want to ask about the healthcare workers. And there is a very various diversity in communities, like they have their own regulations, they have their own pandemics, and they have own character of their community. So I want to ask, how are you going to manage this diversity, since it will need specialized healthcare workers and the system? So if you could have any recommendation about this, it will be really appreciated. Thank you very much.
So, as you know, we are live streaming the event, and I'm getting questions from people reaching us. Up to now, we have a reach of 5,500 people worldwide. The question I would like to ask you, or to any expert in the room, is from our previous GC member from Afghanistan, Dr. Ahmed Ramanzai. He highlighted that in several countries in the Eastern Mediterranean region, people suffer from conflict and struggle to expand the delivery of immunization service. The coverage is low and getting lower as the conflict spreads. The question is, health workers are struggling and are not finding a way to address this issue. Do you have any lesson from countries or organizations that could help improve the delivery of immunization service in conflict setting? Thanks.
Okay. Hi, I'm Elizabeth. I'm a master's student at the London School of Hygiene and Tropical Medicine. And I had a question relating more specifically to your intervention about Indigenous peoples. Having studied in Canada, I was acquainted to the story of the First Nations over there, and I mostly learned about the way in which medicine can also play a very oppressive role or have a very oppressive history. And so with regards to that, I was wondering whether you had any recommendations to reconstruct the trust that has been broken, more specifically between the field of medicine and Indigenous peoples.
Jon Wardle with the International AIDS Society next door here, where we host a program called the Global HIV Vaccine Enterprise. And I find the conversation so far very interesting and fascinating, but also very much worrying. It seems we have tremendous difficulties delivering existing vaccine. If we were to have an HIV vaccine in the next 2 years, and that's a real possibility, or if there was a new disease X occurring suddenly, how will we manage delivering quickly, immunizing population, large number of people? What can we do now to better prepare for this, at the same time, opportunities, but also risks?
Okay, Deborah Klein-Walker from the American Public Health Association. I've done a lot of research, especially around influenza vaccine, which may be a privilege of a first world nation. But in doing that, it is very interesting that the healthcare workers themselves are some of the ones who do not get vaccinated. So I would be interested in, we have different techniques for having, in your knowledge and attitude, the attitudes of healthcare workers around the world across a range of vaccinations. Thank you.
Thank you. I'm from China citizen. I want to about vaccines hesitate in the world. What your suggestion? How deal with this problem? In the world, I think the increase in this tide about the vaccines hesitate. Vaccine hesitate.
I'm Celine. I'm an intern here at the Federation, and I'm also a public health student at the University of Massachusetts in the US. And at my university, early last year, there was a meningitis outbreak, the bacterial infection. So the nursing students, undergraduate at my school, there was like a public health crisis. So basically the nursing students set up an initiative to vaccinate all of the students on our campus, and it was very successful. 2 students were hospitalized, and out of the 28,000 students at my school, because of this vaccination. So personally, I saw the positive effects of the vaccinations at my level, just in our 20s. So my question was for Professor Jon Wardle, if you can speak to maybe your experiences in a university setting with students and how you think students impact the vaccination campaign.
questions. I'm going to start with Adrian this time, Bruce, and end with you. If you could either respond to the questions that you were asked, and then also the question around, because we have actually three extremes in terms of vaccination. The one is around the vaccine hesitancy, which is a particular problem in one part of the globe, but of course is increasing, in other parts. We have the vaccination in conflict and war-torn areas, and then we also have the problems of capacity and resource constraints in large parts of Asia, South America, and Africa. And it's around dealing with those multiplicity of challenges that some of the speakers alluded to. But Adrian.
Can I begin by saying, for those who don't know, I was in Zaire in '95, and also been in quite a few of the conflict zones in Central and even East Africa and the Horn of Africa during and before some of the outbreaks. So I do appreciate the challenges involved around offering vaccination in conflict and war zones, when actually there are probably other more pressing health issues taking place. So it's not an easy one. I just acknowledge that. Can I also just say, with the utmost respect and diplomacy, some nations here will vaccinate their people whether they want to or not, I would imagine. That the facilities available for some to actually say you will be. And so I want to say that that's a reality. Also, for those of us who live in other countries, that's not entirely the case, I imagine for most countries. And I just also acknowledge one of the ways to arrest some of the issues in places like Canada. I say New Zealand's more like Canada than Australia. We've got better table manners. But one of those things is, in Canada, if you're looking on the eastern seaboard, where you're looking at 400 to 500 years of colonisation, we tend to do more things on the other side, the Northwest Pacific, where they were colonised at a similar time to us in Australia. So it's a different kind of relationship. So in saying that, one of the beginning places is just to acknowledge some of the immediate things, that Canada, being the good country that it is, needs to kind of get over the goodness and actually acknowledge, start with residential schools and other things, and just slowly take that opportunity. And I'm going to say one last controversial thing. I said in Boston a few years ago that one of the issues, there is no place for Indigenous America, because white America is still coming to terms with its relationship with slavery and African Americans. Therefore, those that have kept the place warm for 15 millennia, are kind of reserved to the reserve. And that's so even good places who are doing good things still need to kind of take that place to acknowledge the truths of history in that process, which is not a terrible thing. It's good for the soul and even better for Indigenous folk.
So Adrian, maybe I can be devil's advocate and ask you, let's say the United Nations ask you to be the chief advisor, and we're talking specifically on the topic of vaccination and reducing inequalities. And your focus is the 380, 400 million people. What would be one message that you would give to the Secretary General?
A controversial response would be, in my experience, when you get 10 to 20 public health physicians in a room and you close the door, they'll almost always say legislation and intervention.
No, but forget about those 20 public health physicians. You are now the chief advisor. So you have the power for that one intervention.
If there was one intervention, it would have to be more of a philosophical one, lined up with the pillars of the WHO right now. And it was alluded to before, you need to gain the trust of all the people, no matter whether they're in a first world or a rich economy or a developing economy. Earning the trust of Indigenous folk is not going to be an easy one, but we're in the middle of a 10-year vaccination plan at the moment. So it will take time, and we have to trust the people in those countries to do that, earning trust.
Okay. John?
Thank you. So just in relation to the university student question that I was directly asked, I think one of the things that this potentially raises, certainly in Australia and other places, is that even though in Australia vaccine hesitancy dominates the debate, there are still enormous access issues throughout much of the community. And I think putting it onto students to actually keep up to date with their vaccination records and get actively vaccinated, that really abrogates the universities in their responsibilities they should be showing to students. So I think we need to think of access as much as vaccine hesitancy in a place like Australia. Certainly when I worked for one of the primary health networks, we found that the lowest rates of vaccination were actually in areas that were high casualisation of the workforce, low car ownership, poor public transport. The people would have their boss call up to say that they've got an extra shift, that was their GP appointment to get their kids vaccinated, and they just forgot, or couldn't get access to another GP appointment. So I think all these access issues, and it's hard to get vaccinated as a student in most universities. I think that's the reality, and I think that's something that needs to change. And in terms of the vaccine hesitancy question that was asked before, I think we often neglect to acknowledge that vaccine hesitancy isn't one homogenous issue. There are so many reasons that people don't vaccinate their children. Sometimes it's because it's a natural health approach, sometimes it's a fear campaign around pathologization of autism. The goalposts are always shifting, and what really we need to focus on is developing tailored strategies that actually, micro-targeting strategies, just like are winning elections for multiple countries around the world now. We need to embrace those technologies and those achievements to actually focus on what the parents themselves or the people who need to be vaccinated are concerned about, rather than actually trying to give a one-size-fits-all approach.
And your final message, John?
My final message? Well, because of where we work in TCIM, we do see a lot of vaccine hesitancy and people that are probably unfairly cast as anti-vax. And one thing I do want to actually just point out is that I think we often forget that parents who don't vaccinate and parents who do vaccinate, their shared commonality is that they're both trying to do the right thing by their children. And that's the kind of languaging and framing that we need to do. And I think we need to be very careful that we don't politicise or ostracise people that don't vaccinate just because they haven't got the choices, because that's the number one way that we can ensure that they don't actually come into the vaccination fence.
Great, thank you. Viviana?
There were a couple of questions, one of them addressing the fear of our own health workers. Health workers are members of the community, and we need to use principles of community engagement to understand what are the fears. We think of ourselves as experts, but the expertise happens in the community, and we have to learn the skill sets to use principles of community engagement to find out, understand what is going on, and why is it that the fear that we see through the media, through the issues that were already discussed, is perpetrating every aspect, to even highly educated people deciding not to vaccinate. So I really think it's principles of community engagement. One of the things that I also worry about is there are not enough members of the healthcare field, among the health workers, among physicians and among nurses, that belong to the minority and underserved communities. When we look at the numbers of people who are among racial minorities in every country in the world, they're the least represented. And until we put together a campaign to really look at who is not represented there, we're not going to end up hearing and representing those communities at the same time.
And your final message?
We need to engage community, we need to learn why is there that hesitancy, and educate ourselves so that we can educate others.
Okay, great, thank you. Bruce?
So I'm going to start with my final message, and I'll end with it as well, but it's basically the message that Dr. Tedros gave yesterday. There was a session that many, I think, saw, was about vaccine acceptance, vaccine hesitancy, and vaccine confidence. And he ended that session by saying that universal health, you can't have universal health care without universal access to immunizations. And I think that's the top message and it's the bottom message, because I think that while there's this focus on hesitancy, we really need to understand what essentially the differential diagnosis of under-immunization. There are many reasons. It could be access, it could be quality of services, it could be costs, It could be concerns real and unreal. But I think without understanding, as a physician, you don't want to treat somebody without knowing what the diagnosis is. I think in the same way, we need to understand in each patient and in our communities what the reasons are for under-immunization. I do want to take a couple, you had such great questions. I want to touch on a few of them. The one from the HIV vaccine community I think is really important. That if we're having difficulty delivering vaccines that are currently available, imagine how much trouble we're going to have with vaccines that are not yet available. And I think it's an important thing to keep in mind. When I was in government in the United States for many years, I would probably say once a day that there's a vaccine world and a vaccination world, and there's not really an arrow that connects them. They're very separate worlds, and we need to make sure that each side understands where we are with that. I also think that in the context of global health security, we have a real opportunity here of fixing these everyday systems. That if we don't have immunization systems that work now, when we have a public health emergency and need to deliver vaccines, either vaccines that we know or vaccines that we don't yet know, we're not going to do very well. So we need to make sure that the systems are working. And this is the opportunity now in service of public health security is to make sure our everyday systems are working. Influenza was a great example. That's our seasonal epidemic every year. We've become quite complacent about it, but I think that all countries should have that, should look at that as the opportunity to see how well that system functions, in large part because that brings in other than children. We're very good in many countries about childhood immunization, even where there are differences. With adult immunization and adult immunization beyond childhood, it's much more variable. And in a public health emergency, everybody's going to need to be involved. So I think that influenza gives a chance to look at that more broadly and to examine our systems, how we're doing. And it's an annual drill that we should use to test. And then finally, the question from the pharmacist, as far as how to get, I translate this into an access issue of how do we make sure that there are as many points of availability of vaccine as possible, because we know convenience matters. In the United States, the pharmacies in the United States have taken this on in a huge way, starting with influenza and then moving into other vaccines, primarily for adults. But it depends on the states, and there are state laws for this. So I think the answer is that has to be done country by country. And the recognition that this is an all hands on deck, this is where civil society is very important, and all sectors of health and public health need to understand that they all need to be involved, and to try to then see what they can do individually in different sectors within a country and collectively, because it's a whole of society issue. So I'll end with what I began with universal health care is nothing without universal immunization.
Great, thank you. Colleagues, can we give a round of applause to our panelists?